We have now come to the final session before the tea break, and the topic is on asymptomatic kidney stones. As the moderators, let me cordially invite the following esteemed individuals to the stage: Dr. Dimantha Silva and Dr. V. Thanushan. Over to you, Dr. V. Thanushan, to introduce the revered speaker for this session. Thank you.
I welcome Dr. Munipriya Willaraarachchi on his section Asymptomatic Kidney Stone. He is a consultant urological surgeon in DGH Gold, and he had his training in Colombo National Hospital and United Kingdom. Over to you.
Thank you very much, Thanushan. Good morning, Chairperson, sir, ladies and gentlemen. You all welcome to the first plenary lecture in 25th Anniversary Urological Surgeons Congress. So my topic is asymptomatic renal calculi. There is no conflicts of interest. When we come to the asymptomatic renal stones, which is very commonly detected incidentally with more ubiquitous imaging procedures doing nowadays. Because of that, we will find more and more asymptomatic renal stone. So when we come to the prevalence of the renal stones, lifetime prevalence is about 1 to 20% and varying according to the age, gender, geographical location, and the certain factors like the ethnic, dietary, and the genetic factors. The highest prevalence is in the southeast area we call the stone belt. Usually 10 to 15% of prevalence is there. About 50% of recurrent stone formers we will found in one lifetime's time, and the evidence of true prevalence of asymptomatic renal stones is unknown in adults. Because of that, the largest study done in 2010 by Cody and at team. According to that study, they were done low dose NCCT KUB among the 5,000 population cohort. What they found was 8% of the people having the asymptomatic renal stones. And other than that, they were found the statistically significant amount of asymptomatic renal stones in the male gender. And statistically significant cohort is developed the symptoms in 10 years follow-up with the patient with diabetes and the obese BMI is more than 30. So what would you do for asymptomatic renal stones? Whether to treat or not treat. So that is the doubt in our hand. So with this, so many studies done, so many publications were published. So out of that, the Journal of Endourology, they published durability of the active surveillance in patient with asymptomatic renal stones, the systematic review. So according to this systematic review, they were found the spontaneous passage of the stone rate is about 3 to 29%. And the symptoms develop about 10 to 70% of patients. And the stone growth 5 to 65%. And the surgical intervention needed for 1/4 of the cohort. So further, another paper is published in Nature's Review Urology Journal in 2012, and then they were try to found when to surgically treat asymptomatic stones or how. According to that study, they were found the prevalence is about 8 to 10%, and outcomes of asymptomatic stones less than 10 millimeter, symptomatic stone events is about 15 to 30%, and the spontaneous passage about 10 to 20%, and size increase 30 to 45%, and the intervention needed 25%. And the asymptomatic stone located in the renal pelvis with more than 15 millimeter size, high risk of progression of the stone size, symptoms, and the need for intervention. So further, they will conclude the ESW is not a suitable method for treating the asymptomatic stones in the lower calyx if it is less than 15 millimeter size. And another study published in 2021, it is a longitudinal study. Should we treat asymptomatic stone concurrent contralateral renal stones? So there were statistically significantly, they were found the prior history of stone history and the prevalence of diabetes and the history of chronic urinary tract symptoms. The patients with those things, we have to do there is a statistically significant doing the surgeries. And regarding the primary surgery, stone location is statistically significant when we do the surgery. Further, the patient who had bilateral surgery and patient who had ipsilateral surgery with asymptomatic concurrent contralateral stone has no difference in need of surgical treatment. There is a statistically significant is there are asymptomatic stones in the ipsilateral kidney, and treating that asymptomatic stone, the statistically significant outcome is there. So they were concluded after 11 years of follow-up. So observation of this asymptomatic contralateral stone less than 6 millimeter does not place these the high risk place this patient at high risk surgical intervention. However, asymptomatic concurrent contralateral stone greater than 6 should be treated. If the patient is younger age, woman, patient with prior history of stone, diabetes, history of chronic urinary tract infection, and the malabsorption gastrointestinal disease patient, we have to consider the treating those patients. And another Arabic Journal of Urology published bilateral same session flexi ureteroscopy for the renal stones. So in that study, they were published no harm to do simultaneous surgery. It is a safe and convenient for the patient. Journal of Urology in 2015 published the prospective randomized comparing shockwave lithotripsy, RIRS, and the mini-PERC by Anup Kumar, and they were concluded the mini-PERC and the RIRS more effective treatment method for 1 to 2 centimeter lower calyceal stone than the ESWL. So in 2022, New England Journal of Medicine published removal of small asymptomatic kidney stone and incidence of relapse. So this, according to this journal, the treatment group is getting more benefits when the stone size is more than 6 millimeter, and the study included both ipsilateral and contralateral secondary asymptomatic stones. Primary outcome was relapse, which characteristic of the growth of stones 1 millimeter, more than 1 millimeter growth rate, and the subsequent surgery is needed for secondary stone formation. And so in BJUI, they were found to have outcomes of the long-term follow-up of asymptomatic renal stones. The asymptomatic renal stones rarely required intervention according to their conclusion. The specific patients is high rate of developing the symptoms, symptomatic events, and the stone growth. They need surgical intervention, mainly the diabetics, hyperuricemia, and non-lower calyceal stones are more prone to get symptoms and they need surgical intervention. When we come to the EAU guidelines, and still the EAU guidelines, there is no proper recommendation for asymptomatic stone management. What they say is still the conservative management is there. The uric acid stones, we can go for a dissolution therapy, pharmacological therapy, and the selective patients need surgical intervention. So the indication for surgery is stone growth, high risk patient for stone formation, obstruction, infection, and the symptoms like pain and the hematuria, and the patient preference, and especially the professions and the traveling, especially the air crew and the marine crew people is very important to get the treatment for asymptomatic stone. So evidence, summary of evidence, still the debatable whether the renal stones need surgery or not. And the other problem is how frequently if we have to follow up these patients. Still the literature is not adequate enough to say how frequently we should follow up these patients. When we come to the AUA guidelines, again, they recommend the active surveillance, but observation we have to discuss with the patient. We should counsel the patient with regard to the stone growth, passage of the stone, and the pain, that means symptomatic events. And so very recently, AUA newsletter published treatment of asymptomatic renal stone. What's the recent evidence? According to that, they have mentioned we have to share the decision with the patient. So urologists have to discuss with the patient, and we have to share the decision whether to do active surveillance or surgery. Surgery-wise, the miniature of surgical equipment, mini-perk, and the flexi-URS, RIRS, with those things, surgical safety is improving. So because of that, patients might more prone to get the surgery done. So the take-away message, both observation and surgical treatment is acceptable in EAU guidelines and the AUA guidelines. Observation should decision between the patients and the urological surgeons. Surgical intervention is benefit in diabetes, obese more than 30 BMI, recurrent stone formers, chronic urinary tract infections, social situations like the profession and the traveling patients. And miniaturing of urological instrument is cause low surgical complications, so more safe in surgical intervention. However, we need more and more randomized control trial to get the proper recommendation from the guidelines. So multi-center randomized control trial will be held in future.
Thank you very much, Dr. Munipriya. That was an excellent presentation, and sorry for the technical glitch. Due to the time restraint, there's a place for one question. So far we don't have, we'll conclude the session.
Thank you very much, sir. And we sincerely apologize for the inconvenience caused during the session. Let me now cordially invite Dr. V. Thanushan to hand over the token of appreciation to Dr. Munipriya Willaraarachchi.